Hello, and thank you for joining us for today's Great Challenges live event. I'm Amy Lynn Smith, and I'll be moderating today's discussion, which will run about an hour. I'm a writer and strategist who specializes in healthcare and issue advocacy, when I've been focusing on the Affordable Care Act and Medicaid expansion in recent months. I was also a delegate at TEDMED this last April, and I participated in the Great Challenges Day workshop on the science of storytelling. This session is part of the Great Challenges program sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to look at the most complex problems in health and medicine, issues that can't be solved with a magic bullet or a one-shot cure or policy. Our current focus is on the natural overlaps and co-indications between the Great Challenges. We'll be taking questions from viewers on Google Hangout and on Facebook and Twitter. We're on Twitter at TEDMED. Just tag your questions with hashtag Great Challenges, and we'll do our best to answer them in the time we have together. Today, we're focused on the impact of poverty on health and the faster adoption of best practices. Specifically, what has the latest research identified as the best options to better identify and address what's known in the research community as social determinants of health? That term may be unfamiliar to some. It's defined by the World Health Organization as the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces: economics, social policies, and politics. We are delighted to welcome a great team of experts from across these topics to lead the discussion. Today we have with us, if you'll bear with me while I turn my script page here, today we have Bob Atkins, who is an associate professor at Rutgers University. Bob currently serves the Robert Wood Johnson Foundation as National Program Director of its New Jersey Health Initiatives program. Bob has worked as a school nurse, researcher, and recently founded a nonprofit youth development program. Sonia Sarkar is the Chief of Staff to the CEO at Health Leads, supporting its vision of a healthcare system that addresses all patients' basic resource needs as a standard part of quality care. Sundeep is a postdoctoral fellow at Harvard Medical School and co-chair of the Young Professionals Chronic Disease Network, a global group of 400 young professionals from 50 countries committed to the equitable prevention and treatment of non-communicable diseases. Dr. Ann Beal is Chief Operating Officer of the Patient-Centered Outcomes Research Institute. A pediatrician and public health specialist, she has devoted her career to providing access to high-quality health care through the delivery of healthcare services, teaching, research, public health, and philanthropy. Finally, our guest for today's Hangout, Mindy McGrath. Mindy is the Director of Government Relations with the Association of Academic Health Centers. She joins us today to share a new initiative from the AAHC called Where Health Begins, an online social determinants of health toolkit for health clinicians, patients, and community members, featuring best practices and case studies from academic health centers across the U.S. Welcome, everyone. To open this dialogue, let's turn to Mindy. Mindy, Where Health Begins has quite a few components and resources. I know the community had the opportunity this week to read about it a bit on the TEDMED blog, but would you give us a brief overview of how this project came about and what it hopes to achieve?
Sure. Thanks, Amy. I want to start just to lay the groundwork by giving everybody what our definition of an academic health center is. I know it's not a term that's widely used, so we want to make sure we're all on the same page. We define an academic health center as an institution that has a medical school, at least one other health profession school, and then either owns or is affiliated with a teaching hospital. So these institutions are the whole health complex at a university, and they cover the three functions, which are the education of the future health workforce, the conduct of biomedical research, and the delivery of patient care. So we feel here at AAHC that academic health centers are uniquely positioned to be effective in addressing the social determinants of health because they have those three components. And they're also integral in the future moving forward with improving health and well-being because they're involved in the training of future health professionals and the delivery of patient care in addition to the research that they do. So we started an initiative a couple years ago at the urging of two of our member institutions, the University of New Mexico Health Sciences Center and the University of California, Davis. And we have since hosted 2 meetings, bringing together our leaders from academic health centers with other stakeholders, governmental public health officials, and other people who are interested in the social determinants of health issue. We since had our most recent meeting this past November, co-sponsored by the Medical University of South Carolina, the University of California, Davis, the De Beaumont Foundation, the CDC, and the Robert Wood Johnson Foundation. And part of the Robert Wood Johnson Foundation grant was to build this toolkit that we have launched now live on the internet that is designed to be a toolkit for collaboration between academic health centers and public health officers and other community stakeholders to start looking at how we can all work together to improve the health and well-being of our population. And it's a place where we can collect, as you said, best practices, things that academic health centers are doing and succeeding at locally so that we can achieve the ultimate goal of our initiative, which is to build momentum behind a national movement. Our goal is to translate those isolated successes into a broader national goal of all academic health centers, or most academic health centers, being actively engaged in their communities and doing more to improve the health of the community.
Wonderful. Thank you so much, Mindy.
Sure.
And now we're going to go to some questions that were previously submitted. The first question I will direct to Anne. This is a question from Facebook user Kristen. She asks, how can we better align economic incentives with the greater good for public health? Or better yet, how can we take the influence of money and profits out of medicine and scientific research?
So that's actually a very good question, because it really gets to the issue of what are the incentives that are in place for doing much of the work that we want to do, particularly on the side of prevention. And so clearly there are financial incentives that are in place for delivering care. There are financial incentives in place for dealing with surgery, for getting people into hospitals, but there are really no financial incentives in place for addressing prevention. And so I think that this is an important question, because we all know that prevention ultimately has the ability to actually not only prevent disease, but over time to be able to actually reduce the costs of healthcare, because you're not treating an illness, you're actually preventing it. So I think that that's actually a very smart question. I think one of the challenges that we currently have, though, is that right now those who actually invest in prevention are not the ones who reap the benefits. And by the same token, those who are challenged to be able to deliver care and who are trying to reduce costs are not necessarily going to see those returns. And so from a healthcare perspective, we're actually now starting at the national level to see a lot of innovation in terms of different models to try to improve quality, to reduce costs, and to try to do what's called aligning those incentives. And so we're seeing work at the VA, we're seeing work at a number of major centers that are interested in trying to think about populations and think about patient care much more globally, and to try to focus on those populations to then be able to reap the benefits of efforts around prevention. I think that this is one of the promises that we're seeing as we're looking at many of the changes that are occurring within health and healthcare in terms of a responsibility which many health centers have to really take on large populations. So whether we're talking about concepts such as the patient-centered medical home or accountable care organizations, what we're starting to see emerge from there is that it's not just about the physician and that patient alone, but it is about the healthcare center or the healthcare provider taking care of a population. And what's actually being built into that are some financial incentives to focus on prevention.
Fantastic. That's great to hear. And before I go on to the next question, I'll remind folks that if you are tweeting about this, please be sure to use the hashtag Great Challenges. We're glad to see a lot of you watching. And I'm going to toss the next question to Sonia. This is also a question from Facebook. This one's from Jennifer. And she would like to know about the interplay between education and healthcare access. Her question is, does having more education make someone more likely to be able to access healthcare? Or maybe better decisions, make better decisions about utilizing healthcare? How do we maximize buy-in on being healthy without marginalizing people?
Thanks, Amy. This is a great question. So I would say that absolutely there have been many studies that show the links between greater education and access to healthcare. But what we've really been focused on at Health Leads is ensuring that patients have access to the information that they need to actually be healthy in the context of a healthcare setting. So the Health Leads model actually enables physicians and other clinicians to write prescriptions for the basic resources that people need to be healthy, things like food, heat, education, job training, employment, and a patient can then take that prescription to where our college students are based in the clinic waiting room, and those student advocates will then work side by side with the patients to connect them out to the resources they need to be healthy. And I think what's important about this particular access point of care is that, as mentioned in the question, it actually enables us to think about the interplay between where patients get access to education resources and where they get access to health care. And the idea is that you can actually bring those two things together rather than having the two systems remain separate. I think the other piece that's important about this question is how do you ensure that when it comes to becoming healthy, the actions that a patient needs to take are actually they're actually feasible and implementable in the moment. So if you're a mom and you've just been told that your daughter is at risk of becoming overweight and the physician says you need to get her into a fitness and nutrition program, how do you make that actionable in real time? And one of the ways that we can do that is by providing services that are available in clinic that could actually pinpoint the fitness and nutrition program that's at a subsidized cost for a patient located just 2 blocks away from the patient's home. It brings a sort of tangible nature to the actions that we would want to have patients undertake in order to actually achieve health.
Great, that's some great information. Thank you, Sonia. Our next question is for Sundeep. This is a question from Med City News. How can we craft several versions of one message, such as move more or watch your sugar, to make sure it's relevant to people in different communities or different cultures? Oh, we're not hearing you.
Do you hear me now?
Yes, there we go.
All right.
Okay.
So
you want to hear every word.
This has been fascinating for me because I'm a medical student now, and I have access to information. I have access to a lot of messaging in public health and clinical medicine. And I found myself this past year, I actually became very unhealthy. I gained about 25 pounds. Became somewhat sad. I wasn't as excited to engage. And I think the solution of a single message is really, really tricky because I had all the messaging possible. I had probably the most access to a healthcare system what one can have in having like incubated it inside of it. And yet I somehow didn't get the message. So I don't quite know what the right kind of universal message would be. But I can tell you this. What kind of snapped me out of it and got me thinking about health, starting to run again, starting to cycle, starting to meditate again, to kind of be mindful again, was people. Some of my friends kind of sat me down like, Sonny, man, like, what's going on? And that ability of someone to reach out and have a stake in my health, and this wasn't financial, this is not commoditizing health, this is people reaching out and sort of touching my soul, that's what got me back. So I don't know if the message is necessarily the marketing campaign. I would say I think it's much more about people.
Fantastic, and I appreciate you sharing your personal story because it really drives home that this is something even experts in the field face, and I love the idea that it's as much about the messenger and how we sort of bring, and this is what we're all talking about today, is how we bring the communities together to improve health. So thank you for that very much. And now I'll question for Bob. This is a question from Alex on Facebook. How do we make living healthy lifestyles and making choices to support a healthy lifestyle patriotic? it create a sense of community amongst all of us, rather than the idea that some are lazy or stupid because they're ill or unfit. So how do we destigmatize those who live with chronic debilitating diseases?
An interesting question, if not a challenging one. It is. I guess there's a couple of different questions in there, and I found it interesting when I thought about this question. And I guess I kind of first thought back to my experiences when I first began working as a school nurse in the city of Camden. As many may know, Camden is a distressed urban community not far from Philadelphia in South Jersey, which is just a couple miles across the bridge, but faces a lot of challenges that many other cities in New Jersey and the nation face in terms of unemployment, crime, distressed educational systems, which make it difficult. And I think so. One of the things that I learned quickly as a school nurse and working in Camden was that the youth that I was working with are, even though they're kind of separated socioeconomically from their counterparts who are living in more affluent communities, they have the same aspirations. I mean, they do want to be healthy. They want to have healthy, constructive adulthoods. They want to take interesting vacations. They want to live in safe places. They want to do all the kinds of things that those in affluent communities want, those with more advantages want. Of course, there's a lot of barriers, and I guess that kind of leads me to this feeling that I think what really we do have to work for is making sure that we are that we're working towards bringing down those barriers and creating opportunities for individuals in these kind of distressed communities to have the same opportunities to be healthy. I mean, so to call it patriotic, yeah, I mean, but I think it's kind of our patriotic kind of ideal, which suggests that we create equality of opportunity, which we don't really have in this country. I mean, I think there's a real kind of there isn't really equality of opportunity. We know that educational systems are uneven. We know that opportunities to access high quality primary care is uneven. So we have those kinds of understandings, and I think it really kind of has to push us that are kind of that have more resources to make sure that we are doing what we can to spread those out. And I think one of the things that I try to do as a professor in nursing is to make sure my students understand that no one chooses to be obese, no one chooses to be poor, no one chooses to be drug addicted. These things that happen aren't a choice. I mean, it's something, and I think it's sometimes. Yeah, it seems simple, but I think sometimes we forget that this is sometimes that a lot of things can conspire against you, and there's a lot of advantages to being born into the circumstances that you're born into, and there also can be on the other side a lot of disadvantages, and sometimes we just have to kind of keep that in mind that people are doing the best they can with the resources that they have, and so if we aspire for them to do better, I think we have to find ways to increase the resources for them. So I'll stop right there.
That was a great answer to a complex question, and obviously something that the community is going to continue to look at, how we can again bring care to everyone across the socioeconomic spectrum and create that sort of equality of opportunity, as you said. That's a great point. Thank you, Bob. We're going to take a question now from the Robert Wood Johnson Foundation Commission on Twitter, and I am going to pose this question to Anne. The question is, does having more education make someone more likely to access health care?
Well, having more education not only gives you the opportunity for more employment, which then comes with it the opportunity to be insured, which then comes with it the opportunity to have access to health care. It also gives you networks and other types of social resources. And so I think one of the things that we need to ask ourselves is not just how do we look at this, and we all know that social determinants have an impact on health and health care and health outcomes. But then the question is so what are we going to do about it? So this is actually something that's been well described for decades and really goes back to some of the early literature that came out of the UK, where they were able to demonstrate that people of different socioeconomic strata have different outcomes, and it is easy to predict who has the better outcomes based upon their social background. But then the question then becomes, so do we just accept that and say, okay, that's just the way it is? Or do we say that really this is a land where, while we may all be born into different circumstances, where you're born, who your parents are, how much money you make, do we accept that as an outcome in terms of, or as a predictor for our outcomes? And so I think one of the things, particularly for people who are working in low-income settings, who are working in the safety net, who understand that patients often come to us with different backgrounds, what is it that we can do to try to address that? And I think one of the issues is that when we talk about the fact that we know social determinants matter, then what do we do in healthcare? So does that mean then that we make sure that there are opportunities for financial access? Do we make sure that as we're delivering healthcare, we understand the community and the social and frankly even the political context within which our patients are functioning? And how is it that people who are professionals or who are working to help different populations can try to address some of these contextual factors? And so some of this is very important for us to understand, but then the question is then, given the understanding, what is it that we're going to do to try to address these issues if we accept that how much money you make or where you're born should not be a predictor of your health outcomes?
Okay, terrific. Terrific. And we have another question, and thank you, Anne. I think that you raised such a great point about how we really need to look at ways to make healthcare accessible to everyone and have it be, I think that's a thread running through every point here, and is I think a key fundamental. So we have a question here now coming from Sally on Google+, and I will pose this question to Mindy. Mindy, the question is, can you talk a little bit about the ability to how we can make talking to the patient more easily reimbursed for healthcare providers? Sally is hearing from doctors that they can't get paid for the very explanations that help people implement behavior changes. And I think that ties into a lot to the work you're doing.
Yeah, I think that is the $64,000 question, right? I think people don't go into healthcare to become health professionals if they don't care about the patients they take care of. But unfortunately, they're operating within a system that rewards for quantity of services provided and not for the quality of those services. So policy barriers are a big part of this conversation. What can we do on a policy level to make it easier for doctors and nurses and pharmacists and all of the other health professionals to address all of the issues that they know are impacting the health of their patients? And one of those ways I think is pretty obvious is, how do we change the way we pay for care? Right now we pay for quantity. How do we move to a system where we are paying for quality and outcomes? And I think there are some movements towards doing that in the ACA. I think we have a lot more to do and far to go before we have completely revisioned that system. And we here at AHC think that a big part that is still missing is looking at the health workforce. How do we make sure that the people we are training to provide healthcare in the future are diverse, they look like the population they're serving, they understand where those populations are coming from and the issues that they face, and they are aware of all of the different factors that are going to affect that patient's health. So that's a very difficult question and one that we are definitely looking at and trying to figure out ways to change.
Okay, excellent, excellent. And given the complexity of the question, Sundeep has let me know that he would like to add a few thoughts as well. So please go ahead.
Thank you, Mindy. I think, first of all, I think kudos to the group for taking the lead on integrating social determinants of health into health professional education. I mean, I think as a trainee, it's really important, and I can affirm that we don't get enough of it. What I would say, and I have a couple of challenges for the group, though, is typically at an academic health center, as I understand it, we have education, research, and clinical service as the sort of three pillars. Could we, should we, must we add the fourth pillar of social justice to the purview of an academic health center? Question number one. And question number 2 is, could this group or the Robert Wood Johnson or TEDMED or all of us sort of re-engage the public on a reimagined social contract? In my mind, the first time that the social contract was developed was in the 1800s with British physicians, and they never once asked patients about what they actually wanted. If we could actually have something that a group to actually start a dialogue on the idea of a social contract rooted in equity, opportunity, and justice, where patients and vulnerable populations were involved, I think it would be an incredible rite of passage for trainees to understand that they must listen and reflect. Thanks.
Terrific, and I appreciate you starting a dialogue here. Everybody,
nice.
Just about everybody wants to start to weigh in, which is terrific. And we'll go in order. Mindy would like to respond to your thoughts there.
Yeah, Sundeep, I think it's an interesting proposal to add a 4th pillar to the academic health center. What is seen as the traditionally seen as the academic health center mission. And one of the things that we've been doing here at AHC is trying to move away from saying that academic health centers have that tripartite mission of education, research, and patient care, and actually look at those as functions of what is ultimately the mission of an academic health center, which is to improve health and well-being. And I would argue that social justice is a key factor in doing that. So I think we're saying the same thing, maybe using different words, but I think what we're looking to do is to bring academic health centers together under the understanding that if it is our job to improve the health and well-being of our communities, we have to get involved in addressing the social determinants of health in order to do that. And social justice is an important element of doing that. So I would agree with what you've posited.
Absolutely. Fantastic. And Anne also had some thoughts to share here, so please go ahead.
Sure. So the only thing I would add is that, when we talk about the social contract, and I apologize for the sirens outside, is that often the measures of success, and I say this having been in academia, so Sundeep, I know where you are because I was faculty up there for a number of years, is that the measures of success were about doing research, were about getting more papers and getting more grants, but there are no measures of success associated with having an impact. So even stepping back, if we wanted to, from a social justice contract, there's actually not even a contract or an explicitly stated contract about health impact or impacting the local communities in terms of health and health outcomes. And so it is often implied, but when we as faculty are promoted or thought about how can you move forward, your ability to impact on the community is not one of the metrics that are used to define success. So now, putting on my hat though as a funder, increasingly many of us are funding not because we want to just give money away for great ideas and to support a research agenda. All of us are funding because we are trying to have an impact on health and health outcomes. And so whether you are from the private sector and organizations like Robert Wood Johnson Foundation or the Commonwealth Fund or others, or working on, say, the federal side and looking at the work of NIH or ARC or others, all of them, what they have to do at the end of the year is to be able to demonstrate that the investments that they've made through funding are actually having an impact on health and health outcomes. And the mechanism by which we do that as funders is to go to academic medical centers and to go to researchers and to go to the experts and ask them to do this work. And so I think increasingly the funding world is actually going to start to hold academia and the researchers there accountable for having an impact and trying to improve outcomes, because that is essentially what we are charged to do. And so I think I agree with you. I think there's a long way that needs to go, but I think our measures of success, and frankly, this whole conversation about aligning incentives, needs to occur among academia as well.
Fantastic. Thank you, Anne. And Sonia wants to weigh in, and it actually ties really nicely into this whole idea of funding. She wanted to comment, to add some thoughts on this aspect of the conversation aspect of care matched with reimbursement, which is obviously an important one. So please go ahead, Sonia.
Yeah, absolutely. I thought the question was a great one, basically trying to get to the essence of how do you get the aspects of care that really are getting to the social determinants of health reimbursed. And I think the dialogue that we've been having since that question really focuses on two levers. One is the short-term lever of what are the economic incentives that are aligning around really focusing on quality of care and on population health. And then the second lever, which Sunny was speaking to, is how do we build a long-term workforce of physicians and other primary care capacity that have both the skills, the experience, the knowledge, and the comfort with actually having conversations with their patients about these issues. And on the first, I think what's interesting is that, although we are currently in a fee-for-service environment, as Mindy was referring to, many of the momentum within the healthcare system and the movement that's being initiated by health reform in general is putting us in a place where increasingly there is demand in healthcare institutions to understand how addressing social determinants of health could impact very sort of proximal metrics that matter to healthcare institutions. Things like patient satisfaction, physician retention, enabling the clinic professionals to operate at the top of their license. And so really measuring the ways in which interventions that connect patients to to resources that address social determinants of health tie back to those economic incentives can have a major impact on this. On the second lever, I think one of the long-term trends that some of those economic incentives will also result in is a shift in the way that we start to prepare physicians and other healthcare professionals for the sort of new 21st century model of healthcare. And I think to your point, Sunny, we need to really think about how we can integrate not just information about social determinants of health and sort of the academic statistics about the ways in which different social determinants impact health outcomes, but what are the practical things that healthcare professionals can actually do with their patients in real time in order to address those particular needs.
Wonderful. Question from, I have to scroll back here because we've had so many coming in, it's great. We have a question from Twitter as where is an individual's desire for health addressed or measured, and what is being done to make people want to be healthy? And Bob had wanted to talk a little bit about matching healthcare workforce with the population served, and I think that ties really nicely into that question. But Bob, since you had the idea, I'll let you sort of run with that as you see fit.
Okay, thanks, Amy. Yeah, I mean, some of this excellent kind of back and forth around social determinants and ways to address some of the barriers we have in terms of access. I think one of the pieces that we are thinking about here, obviously, the Robert Johnson Foundation is very invested in making sure that the healthcare workforce matches the populations that it serves. And I think sometimes what we end up doing, I know working and putting my hat as an academic on from a nursing school perspective, is what we try to do on the back end is acknowledging that we have, let's just say it, I mean, most of our nurses that we're producing are European middle-class Americans and female, and so we try to do a lot of cultural competency on the back end, which is less than the ideal, and I think we have to find ways to tap other pools of potential healthcare providers and make sure we're bringing them into the healthcare workforce so that this workforce is closer matched up to the patients, because we have a lot of evidence to suggest that that as we are able to better align who's taking care of our patients with the patients in terms of background, not just talking racial, ethnic, but kind of also cultural background, we know that we can get kind of better outcomes. And so I think one of our focus has to be to figure out how we're going to bring out, because there are a lot of individuals out there that would love to be physicians, dentists, nurses, nurse practitioners, but they're not really thinking about that. And some of it has to do with kind of the financial barriers to it. Some of it has to do with some of the advising that they're getting. But it's always kind of a little bit sad when you find somebody that says, "Oh, I'm 40 years old. I'm an accountant, or I'm doing this profession because I didn't think that I could have done nursing or medicine or dentistry," and that's another person that we lost, especially when there's a person of color, a person from a background that you realize, oh, the person would be a great provider. So I think we have to find other kind of models that make sure that we are bringing other people and other individuals from different kinds of backgrounds into the healthcare workforce. And I'm not sure how much that touches on the other question, but I think that I've said enough for right now.
Well, I think it's where I saw the connection was the idea that if we have a more diverse, workforce and finding, healthcare workers that really, can relate to the patients they're serving, I think that might be a way to
Yeah.
really help address that question. So
Thanks, Amy. That does tie it in.
You did just fine yourself. And we have now a question from Jenny on Twitter that I will pose to Mindy, because we had talked before this chat a little bit about community. And the question is, how do we bring communities, particularly those with limited resources, together to improve health? So that one's for you, Mindy. Oh, I think we've lost the connection with Mindy momentarily. Is there anybody else who'd like to jump in and talk a little bit about getting communities involved with working together to help improve care? And I'm looking at the question again here. Really working with communities to strengthen this idea of social determinants of health. One example that I can think of is here in Detroit. We have Keep Growing Detroit, which I met at TEDMED, where they're doing community gardens and growing food. And Anne is gonna jump in here. But we see that was one example of ways communities are coming together to grow their own gardens and have healthier food choices in Detroit, which is a food desert largely. But Anne is going to take it from here.
Sure. So I haven't yet had a chance to really talk much about the Patient-Centered Outcomes Research Institute, which is where I currently am. And basically, the premise of PCORI is that we are a comparative effectiveness research institute, but we feel that it's very important to make sure that our research agenda is informed by patient priorities, that we ask the questions that matter to patients, that we look at the outcomes that matter most to patients. And so in building this agenda from a research perspective, what we wanted to do was understand more about patient advocacy and patient engagement in other parts of health and healthcare. And so I've had an opportunity to learn a lot about patients as they've gotten involved with issues such as patient safety and the prevention of medical errors. And we've also had an opportunity in terms of thinking about it from a research perspective to learn a lot about the whole agenda related to community-based participatory research and to understand that patients actually are acutely aware of some of the challenges that exist in their communities. And so when we as researchers or as academics or as healthcare providers come in and say, okay, we think that these are major issues and we'd like to work with you and help you, they're saying, well, quite clearly we know what it is that functions in our own community. So for example, a couple of weeks ago, my team and I had a chance to go down to Memphis and to do site visits and to hear about some of the work that we're supporting in Helena, Arkansas, where they were doing major initiatives around addressing issues of mental health among rural African Americans. And that was a project that came about because people started to say, these are the challenges that we have in terms of people feeling isolated, in terms of people recognizing that they have chronic conditions, but they don't necessarily feel empowered and able to take care of those conditions. And a big part of it is because of the mental health challenges that they had. So I think there's a very rich and robust experience that we have, which actually is manifesting in research, but it also manifests in terms of care, and it has manifest in terms of the community-based participatory research agenda that we see popping up around the country.
Wonderful. Thank you so much, Anne. That's an excellent question, an excellent answer. And the next one we have from Stacy on Twitter, and I think this is a great question for Sonia, given the work that she and her organization do. Are there any new innovative point of entry ideas for care access, such as Stacy, the questioner, Stacy, yes, asked about drugstore clinics and grocery stores coming to mind. Are we seeing those is there a trend, do we think, in those kinds of access points growing?
Yes, I think this is a great question. So certainly, I think one of the trends that's really come about in light of the momentum that's currently taking place in the healthcare system is, where do patients most often think about health, and where do they access healthcare, and who do they trust to give them information about the ways in which they can get healthy? And I think, interestingly, one of the places that often isn't talked about in terms of where can people go to actually get healthy is the healthcare system and healthcare institutions themselves. I think mostly because for many reasons up until now, healthcare systems have been places that are primarily focused on care and treatment after a patient gets sick rather than on preventing the patient from getting sick in the first place. And so I think, one of the areas that we've been focused on certainly is how do you repurpose the clinic so that it is actually a place where patients can go to access the resources that will actually make them healthy. And also at the same time connect them out to different access points that will enable them to be able to do things like buy healthy and nutritious food, exercise in their neighborhood, get access to childcare so that they can actually pursue employment that's sustainable. And so I think in thinking about the different access points for care, certainly there are amazing models that have looked at using farmers markets, using, as you were mentioning, the drugstores, using the local park or the community garden. But when you think about a hub for all of those different resources to connect to one another, we really focused on actually using the clinic as the place where patients can most directly get access to all of those different services.
Fantastic. Great. Great. So we're definitely seeing that as a trend, and I think that's really important, and the more access, the better. We do have a question from another Stacy, and this one's for Mindy, now that we have her back. Good to see you, Mindy. How does the United States fare in comparison to other countries in recognizing and dealing with social determinants of health? I understand you may have some data to share with us on this.
Yeah, that's a really interesting question, and I mentioned to Amy, we talked the other day, there's a chart put together by the Organization of Economic Cooperative Development that there's two charts actually. One charts the healthcare spending, comparing the United States with all of the other OECD countries, so Western developed nations, and as I think we all know, the U.S. is a huge outlier when it comes to healthcare costs. But if you then compare the United States to all those other countries and you combine healthcare costs with spending on social services, the United States is right in the middle of the pack. So what that would indicate is that all of the other OECD countries, or many of them, are spending more of their dollars on upstream causes of health problems, whereas the United States is putting more of their focus on dealing with the downstream consequences of the things that cause health problems. So I think there's a real disconnect there, and one that we're moving in a direction of trying to address, but I think we still have a lot of work to do.
Great. Thank you. Wonderful. The next question comes from Andre on Twitter, and I'd like to toss this out to Bob. The question is, how do we bake in sustainable prevention? For example, building environment for communities, using their feedback to make it relevant. I think that again ties back to sort of making the workforce, the health workforce, connect better with the patients they're serving.
Yeah, I mean, obviously, there's a greater attention paid to the role that environments play, and one of the things that really I've been very interested in is how unhealthy, stressful environments, how the toxins in environments, not just the ones that we breathe, but sometimes the ones that we're exposed to, how they influence stress levels and influence eating patterns and exercise patterns and just ways of kind of relating with each other. And again, this is kind of comes from the work that I did in Camden as a school nurse, and then my work in working with youth through the youth development program that I co-founded. But yeah, so how do we bake it in? I mean, I think one way to bake it in, obviously, is we have to kind of start early. I mean, we have to start early. We have to kind of make sure that we're finding opportunities for children and adolescents to get engaged in ways that they're going to improve their health. And so, you know, one thing that we kind of had some opportunity to think about was ways that we could increase access to healthy exercise opportunities, right? And so we know that because of some of the exposure to crime. A lot of parents in high poverty, stressful environments keep their kids indoors, and we have to sometimes find outlets and find ways to take children and adolescents and give them opportunities and make it and find safe ways we could kind of get them engaged with the environment. And that's not necessarily just within the environment that they live in, but also kind of opening things up. So one thing that we did with our youth development group was had a summer camp where we took kids out of the city for a week every summer to Vermont. And this was great for kids in Camden who, a lot of them had never been on the New Jersey Turnpike and were just excited to be on the New Jersey Turnpike and going over the George Washington Bridge. And that was always kind of exciting to be driving the bus to hearing all that kind of, and realizing that the environments that they're exposed to are in some ways just not expansive enough. They just have a very kind of narrow view. And I think one thing we have to do is make sure that the extent we can, that we expose our children and adolescents, especially in distressed environments, and especially our vulnerable populations, to this greater world outside, and find ways to connect them to, we know, for example, another thing we know that's really kind of helpful for kids, it's stressful, but it's helpful, are things like backpacking. Take kids camping and backpacking, getting them out. And so obviously the things we want to do within neighborhoods, like kind of create walkable paths and safe neighborhoods and you know, those kinds of measures, but also I think we have to think about things that we can do with youth that will expose them and kind of set them up for healthier lifestyles when they start to hit adulthood, because we know that the behaviors that they start to adopt as children and adolescents, they're going to determine what's going to happen 5, 10, 15, 20 years down the road. They're not going to see it immediately, but it's kind of, we have to do it early. So in that baking in process, I think we have to start baking in some of the healthy components very early. And so, yeah, I think that's enough for me right now.
It's an excellent answer. I think it's a great point about starting early. So thank you for that, Bob. Carrie had a question. I guess my mentioning of Keep Growing Detroit prompted this question in community gardens, and I would certainly, as a Metro Detroiter, I was pleased to see this good news story at TEDMED, and you can certainly watch Ashley Atkinson's presentation online. I would urge you to do that if you're interested in that, Carrie. But she has a question for the team. I think is a great question for Sundeep, which is, you know, how can we bring people of limited resources together in a way, in such a way that we can create opportunities like that, whether it's a community garden or some other way to work together as communities to improve health.
Yeah, so I'll start with a really nerdy analogy. I trained as a PhD in microbiology, and I mentioned this in my TEDMED talk, but I didn't have time to expand on it. One of the things that inspires me about community building is something that amoebas did 100 million years ago. And the secret is they faced a crisis. And so the crisis for these unicellular amoebas 100 million years ago was that they needed food. And so until then, evolution had basically been very siloed, and you had amoebas that were all separate. But because they needed food, for the first time in evolution in history, one amoeba reached out and touched another amoeba. That amoeba reached out and touched another amoeba. So sooner or later, for the first time, you had basically a slug-like creature that was composed of individual amoebas, but moved with a collective polarity towards a food source. After it got to the food source, they arranged themselves where 80% of the amoebas would sacrifice themselves, so 20% could get to the top and find other pastures. So it actually teaches me a lot of things about how I'm a community, or at least I try to call myself a community organizer. I've tried to organize a bunch of young professionals, not just doctors or nurses or med students, but people in psychology, people in philosophy. And now we've grown from 450 countries to about 2,105. And a lot of them are from low resource environments. A lot of them are young and hungry. And social media has provided what I would call a petri dish for us to form a modern slime mold. And I see completely as what Bob was saying, that the people who are in their teens and their 20s today are going to be the patients of tomorrow. And we don't want to be sick. And we see the data that suggests that in rich countries, this could be the first time in history where we might not live as long as our parents, and so on. So I think the way to do it, in my mind, is to create a crisis. And I think it's tough for people to see a crisis. I see this in med school every day where patients are like, oh, doc, I didn't know my blood pressure was in the 180s. It's tough to see. With something like Ebola or something like malaria that my PhD was on, it's much easier to see. So to make that visible is I think number one. And then to be very clear that this is a crisis, that our population across the world is suffering. It's causing $47 trillion in economic loss by 2030, according to the World Economic Forum, just on chronic disease alone. So yeah, that'd be what I would say, is make the marketing pitch a crisis and get the young generation to organize, use Twitter, use Google Hangouts, leverage TEDMED, and build a slime mold.
And that's one of the best nerdy answers explained.
I'm a nerd. I mean, I'll just admit it.
But I love how you made it understandable for everyone. It's innate in all of us, and we can make this happen. So
that's exactly right. It's
that.
hardwired into us.
Exactly. So it should come naturally if we just.
I mean, if amoebas can do it, then so can we.
Exactly. I love that. That's fantastic. It's good motivation for us to remember that. Our next question actually is specifically for Anne, Dr. Beal. This question comes from John on Twitter, and he wants to know if the Affordable Care Act will increase health coverage for the poorest Americans, and if so, how?
So the simple answer is yes. We currently have estimates that there are about 50 million, over 50 million actually, people uninsured in this country. And the estimates are that over time, the Affordable Care Act are going to allow us to provide coverage to about 30 million of those people. That still means there's about 20 million people out there without coverage, but at least we're making steps in the right direction. And without going deep into the primary mechanisms by which that is happening, but it's really a series of steps, including everything from expanding Medicaid to making sure that there are standards that go from state to state to make sure that a poor family in Alabama has the same kind of financial coverage as a poor family in New York. In addition, there are other incremental changes that are coming in as a result of the Affordable Care Act. So the one that made my children particularly happy was the fact that they are now covered under my insurance up to the age of 26. And so that definitely got their attention. And so those kinds of expansions are allowing us to bring more people into coverage. But I think one thing that is important to know, and this is something that we had talked about actually in some of the materials that went on out before, is that access to care is only the first step. Then the next thing is, what is the quality and the caliber of care? And then ultimately, when we're talking about health outcomes, how much does really care contribute as compared to community, stress, and all those other factors? And so one of the things that I want us to start to think about is the role of not only social determinants, but how then do we make people understand that they have opportunities for self-efficacy, that they have opportunities to essentially control their own destiny. And so there are these concepts of self-determination that really get to the fact that it is not the environment so much that is the stress that you experience, but it is actually your ability to control your environment. And this has actually been done in animal studies, but the same thing holds for human populations as well. And so what we need to start to think about from the context of social determinants and the ability to try to promote self-determination is that when communities are actively able to engage, when they're actively able to make sure that they are no longer food deserts, that the streets are safe to walk, that the schools are high quality, that if they want to take their children backpacking, they don't have to put them on a bus, they can actually just go up the street because there's a decent park in the community. What you find is that increasingly being poor is not the predictor for poor health outcomes. When you're poor but you're able to control your destiny, when you're living in an environment where self-determination is promoted and permitted, then many of the abilities for people to be able to then promote their own health actually start to come out. So I want us to definitely take a focus on the opportunities in the Affordable Care Act for expanding coverage, but recognize that some of these other issues that are very important really are going to have a much broader and long-term impact on health outcomes, particularly for vulnerable patient populations.
Fantastic. Thank you so much, Anne. That was a really great answer. I think it'll help educate people on a topic that there is a lot of still a lot to learn. It's a big topic, the Affordable Care Act, and so thank you for those really important points. We are on to our final question here now, you know, though though the great challenges discussions center around issues that really can't be solved with a magic bullet or a one-shot cure or policy, we can certainly identify smaller, less magical steps or policies that might make a significant impact in the space. And with this in mind, Kelsey asks on Facebook, we all know that there are so many opportunities for changing or improving the health of our cities and communities. Yet with so many critical factors and so many of them inextricably linked together, what are some of the best places to start focusing our attention? What are some of the things we can do and see an improvement in the short term to build momentum and gain hope for the future and more long-term effects? I know that's a big question, and what I'm going to do is I'm going to start with just a couple quick thoughts of my own, and then I'm going to ask each of you to respond quickly because we are coming to the end of our time here. So I'll try to give our kind of concluding thoughts on what we can do now in the short term that will result in big changes in the future. To me, one of the biggest things relates back to the Affordable Care Act. Here in Michigan, we have passed Medicaid expansion, which just that alone, I think is going to be, yes, it's going to happen now, but it's going to change people's lives in the long term. I can't tell you how many people I interviewed when I was reporting on the need for Medicaid expansion who could not wait to start being able to see a doctor on a regular basis, which they could not afford to do. So just that, we see that people want to be healthier, and now they're going to have an opportunity thanks to the Affordable Care Act and Medicaid expansion. So that's my 2 cents, and now I'll kind of go into the order in which you were introduced. We'll start with Bob. What are your concluding few sentences there?
Yeah, I think we have to really keep in mind that I think this has come out through this conversation, is that we are connected, and we are connected with those who are in affluent communities and those that are in disadvantaged communities, and we actually diminish the quality of our own lives and our own health when we fail to keep in mind that those that are less advantaged are they're connected to us, and so if they're not healthy, we're going to pay one way or the other. So since we are connected, we might as well make the investments early. And I think that's one way that we can improve the health of everyone in our society.
Fantastic. Well said. Thank you. And Sonia, what are your concluding brief thoughts?
I would say that one of the very small and easy actions that we can take is think about how to repurpose the systems that are already present in the clinic or the doctor's office and revitalize them to addressing social determinants of health. So one very simple example of this is administering a standard screening tool in the clinic waiting room around whether a patient has enough food at home at the end of the month or whether they're in need of employment, and just having that be part of the standard paperwork that the patient receives when they walk into the clinic, and the doctor can then log that information into the electronic medical record. So we can actually repurpose the EMR, the standard screenings that patients get, and even the prescription pad to some extent to really focus on social determinants of health.
Great. Thank you, Sonia. And Sundeep, what are your thoughts, please?
All right. There are 3 things that come to mind, but number 1, the 3 C's, I guess. One is community. And I think one thing that we haven't mentioned here is, and Sonia's way too modest, but I'll brag on, I think expanding the model that Health Leads and Rebecca Oni and Sonia pioneered, I think involving community health workers. So what better way to involve a health workforce that looks like the population than to involve the population itself? And we've known in India and Sub-Saharan Africa that community health workers have increased health gains by many-fold. They provide critical social support. Number 2 is curricula. I'd go back to this idea of social justice and however we'd like to frame it, either as a 4th pillar or as part of a mission, but seeing at my institution or institutions across the nation that social justice and health impact is the mission. And it's not about publications, it's not about what paper you publish and what journal for tenure, but it's about your impact on your community. That would be game-changing. Number 3 would be change, and I think here, I used to focus always on tobacco. I think the big issue for the 21st century for me is we need to take a really hard look at our food supply. By 2050, globally, we're going to have to double the food supply, and the subsidy scores and our subsidization of corn and cheese and things of that sort, not just in this country but also globally, is causing incredible preventable mortality and morbidity. So if we don't address food, then we're not addressing anything at all. Thanks.
Thank you. Okay, and Anne, what are your thoughts, please?
So I used to say to my patients that as a physician, my job is to try to put myself out of business. I want it to be such that my patients don't need me. If I were king of the world, what I would make sure is that every community has a grocery store, a good grocery store. So as Sundeep alluded to, access to actually good, healthy, affordable food would go a long way. That would be number one. Number two would be availability of good walking spaces. One, to get to the grocery store, but also to allow people opportunities to not only go out and move, but also to engage socially with their friends and neighbors. And then third is opportunities for access to not only just jobs, but jobs that provide a living wage. And so from a health perspective, really my emphasis would be on making sure that patients actually never need to come and see me.
That's a wonderful and certainly very humanitarian goal to put yourself out of business. And last we come to Mindy. We'd like to hear your thoughts here as we wrap up today.
Thanks. I mean, I think I would obviously second a lot of what everyone else has said, but what we're looking at AHC is how do we, at an institutional level, start to be more strategic about the things that are happening already every day. I mean, I think we know that there are a lot of really innovative, interesting projects that are being done by faculty at our institutions, people at community health centers, whatever it may be, and I think one of the good ways to get things started quickly is how do we have the leaders of all of those institutions talking to one another and working together so that we're making strategic decisions that incorporate the needs of the community. That's my answer.
Fantastic. Well said. And it looks like our time is up. This topic is clearly, impacts all of us in many ways, and we could talk about this subject for quite some time and still have a lot to cover. As a reminder, the entire TEDMED community can share their action commitments around any of the challenges on great challenges and on TEDMED.com/great challenges. You may even be featured in an upcoming hangout with our challenge team. So be sure to check that out. Again, it's tedmed.com/great challenges. Don't hesitate to jump on the community pages to ask your questions. We don't have time to get to today. TEDMED will connect with the experts and post their response. You can also join us on Twitter at #GreatChallenges. We welcome everyone's input. Our next Google Hangout, Shopping for Health, will be on Thursday, September 19th at 11 a.m. Eastern. We'll be joined by our obesity and childhood obesity team members and the Food Marketing Institute to discuss consumer behavior and health awareness inside the grocery store. Thank you to everyone in the TEDMED community, the team members, and our guests who participated today and made this event a great success. Finally, we want to say thank you again to the Robert Wood Johnson Foundation, sponsor of the Great Challenges program. Goodbye, everybody.